We now go on to the next session, which is a very important section on vaccinations and inflammatory bowel disease. For chairing this session, we have Professor Vandana Midha, who is a professor of medicine at DMC in Ludhiana and has a good amount of work in the field of inflammatory bowel disease. We also have Dr. Vikas Suri from the Department of Medicine at PGI Chandigarh. Over to you, chairpersons.
Yeah, good evening and thank you. First of all, I would like to congratulate the entire organizing team for this excellent show going on today. And without wasting any time, I'll go straight to the topic and the speaker. Vaccinations in IBD patients. It's a very important topic, but often a neglected topic. And we all need to put it on the radar screen of all of us. So I invite Dr. Manish Singla. He's a gastroenterology specialist at the Capital Digestive Care, Delmar, MD, USA. Over to Dr. Manish, please.
If someone can let me, never mind, I got it. Thank you. Okay, so I don't need to re-say what we're going to talk about today. We are going to talk about vaccines in patients with inflammatory bowel disease. I want to plug something that I have always taught our fellows, which is preventative care in inflammatory bowel disease is extremely important and never feels like it's the primary issue that we're seeing our patients for. We're seeing them for flares and difficulty with handling their active disease. And so sometimes we struggle with remembering all the things we have to do. So we came up with this way to remember everything that you have to do for your patients that doesn't have to do with colonoscopy and inflammation. This is IBD hints. So I is for immunizations, B is for bone health. So that means getting them their bone density screenings. The D is for dysplasia and depression, and that dysplasia is both cervical and colon dysplasia. The H is for hepatobiliary screening to look for patients for PSC in those who have IBD. The I is for infections to go look for C. diff in our flaring patients, tuberculosis and hepatitis B in our patients that we're going to give biologics to. The N is for nutrition. That's to look for iron and anemia and vitamin D and B12. The T is for tobacco cessation, and the S is for skin cancer screenings in our patients with IBD, particularly those who are on immunosuppression. We find that we even write our notes this way so that we can remember all the pieces that we need to send our patients for. So let's talk about immunization first. So unlike the United States, that the Indian and the United States universal immunization programs are different. So these are the ones that I've listed off that seem to be covered in India at no cost to children and pregnant mothers. And that's the tetanus diphtheria, MMR, childhood TB or the BCG vaccine, polio, meningitis, Haemophilus, and hepatitis B. And I've italicized the 2 live vaccines because we will come back to the question of live vaccines in children closer to the end of the presentation. So let's begin by talking about influenza. So in the Indian guidelines, we say to vaccinate everyone above the age of 50, and there is patient and physician discretion for those patients who are between the ages of 18 and 49. I suggest that we should be vaccinating everyone who is on immunosuppression and probably everyone who has inflammatory bowel disease annually for influenza. We know that anti-TNF therapy reduces titers. This is a theme we're going to learn about anti-TNF therapy with all vaccines. But that doesn't mean that we shouldn't be given the vaccine out. We know that there's an increased risk of influenza and hospitalizations in patients with IBD. And so this seems like our easiest hurdle to jump over to prevent long-term disease. There is an increased risk of pneumonia in IBD, and particularly that risk is higher in those patients who are on narcotics. And the risk of invasive pneumonia is high within the first 6 months of getting diagnosed with Crohn's disease. Now, the authors of that study suggest that it might be because that is also when we're starting those patients on immunosuppression. And so it may be related to the drugs that we're giving the patients. In our practice, in anyone who is getting immunosuppression, we give them the PCV13, that's the 13-valent pneumococcal vaccine, followed later by the 23-valent, the PPSV23, and then a booster 5 years later. Now, these vaccines are expensive, and I think in India there's also a non-valent PCV, but whatever the local pneumonia vaccine and antibiogram recommendations are, we strongly recommend that patients with IBD get pneumococcal vaccination. The nice thing about pneumococcal vaccination is it can be given while they're on immunosuppression. So you don't have to wait 4 weeks after you've given a vaccine to be able to give them their pneumonia vaccine. Hepatitis B ideally should be checked prior to anti-TNF therapy and is part of both the American and the Indian universal immunization programs. And so we would like to think that most people are vaccinated against hepatitis B already. But for those who are not or have not shown a positive titer, it's a 3-dose series at 0, 1, and 6 months. And then there's some suggestion, because of the worry of a decreased response to the vaccination in IBD patients, you can consider checking the hepatitis B surface antibodies after vaccination. And if it hasn't met threshold, redo the entire series at double dose. And once again, this is another one that can be provided while they are on immunosuppression. You don't have to wait until afterwards or before. Herpes zoster, we know that vaccination reduces the incidence of herpes zoster by 40% in those patients who are immunosuppressed. And at least the live vaccine, the Zostavax as we use it in the United States, we know that we're not supposed to use that in patients who are on biologics. Now, there are some very large rheumatology articles and studies that show that maybe it's safe, but at least per current guidelines, we're supposed to avoid it. And so you can give that vaccine 14 days prior to biologics or high-dose steroids, high-dose steroids being more than about 20 milligrams a day, or 3 months after discontinuing immunosuppression. Now, I really, really dislike these recommendations. And the reason for that is that as gastroenterologists, we receive patients who we want to start on biologics or steroids when we're seeing them. They're symptomatic now. And so the idea that we can put off their immunosuppression for 14 days while we're waiting for their vaccine that they might be able to get today to take place, I don't generally do it. I usually treat their IBD and hope that I can get them to a place where we can vaccinate them. And then there's lots of studies underway on the new recombinant vaccine that's not a live vaccine. And so we're hoping to get more and more information about whether or not we can give that one out while patients are immunosuppressed. The HPV vaccine, I think, is probably the most ignored vaccine in our population. There are 3 different ones available, the Cervarix, the Gardasil, and the Gardasil 9. Now, these are very expensive, both in India and in the United States. And I think it's uncomfortable to talk to your young patients about HPV, STD, STI, and maybe some gastroenterologists are uncomfortable taking a sexual history of their patients. The shots are easy. They're 3 shots over 6 months. They can be done while on immunosuppression. They can be given up to the age of 26. And I think what I really want to hit home is that we have reasonable studies that show that there's an increase in abnormal pap smears in patients who have inflammatory bowel disease, particularly those patients who are on immunosuppression. And we've got lots of new data that there's an increased risk of anal squamous cell cancer in patients with perianal disease. And so I would strongly encourage any physicians who have access to these vaccines to really talk about this in our youngest patients. While I was looking for this data, the burden of cervical cancer in India is much higher than it is in the United States. And so I would hit this home once again, that the HPV vaccine can prevent a lot of morbidity in our patients with inflammatory bowel disease. So let's talk briefly about COVID-19 in the patient with IBD. So you guys already had a lecture about this, so we're not going to talk about this too much. I'm just glad that my slide says the same thing that those slides do, which is that there doesn't, at least right now, appear to be any increased risk of severe illness in patients with IBD from COVID. So then why are we talking about it? I think our worries are about immunosuppressed patients. We always worry about whether or not anything new we do to a patient who's got, let's say, brittle IBD, that we're going to trigger another flare. And then I think we're all worried about the long-term sequelae, both of the virus and of the vaccine. And so all of these mean that if our patients have any vaccine hesitancy, and our physicians have even 1% vaccine hesitancy, it can spiral into our patients not getting vaccinated. And so I think it is important that we all give consistent and correct recommendations. So in India, available is the Covaxin, which is inactivated, and the Covishield, which is recombinant. And the Crohn's and Colitis Foundation, primarily in the United States, and the IOIBD recommend vaccination. The Crohn's and Colitis UK recommend vaccination. The British Society of Gastroenterology recommends vaccination. The Ministry of Health and Family Welfare from India even have a line that say patients who have chronic disease or on immunosuppression should still get vaccinated. So what we have is maybe the first time in my life that every single society has the same recommendation about one topic, which is that if patients have access to COVID vaccination, they should get vaccinated. Let's talk a little bit about special concerns in pregnancy. So we have now, I think, a decade's worth of data showing that patients who have
मेरे को निकलना पड़ेगा क्योंकि मेरे को चार्जिंग भी करना है 36% पे.
So what we know is that we have lots of data showing that patients who have inflammatory bowel disease, who get pregnant and are on anti-TNF drugs, that those drugs cross the placenta. Now, I think what we know from the European cohort is that it is unlikely that those drugs cause any birth defects more than what we expect in IBD. But what we have found is that babies born to those who are on anti-TNF drugs have titers of these anti-TNF in them. And so in the United States, the only live virus we give out in the first 6 months of life is rotavirus. So that is the one that we try to contact the OBGYN, the pediatricians. Don't give out the rotavirus in this one patient until after 6 months. In India, the vaccination schedule is a little bit different. And that means that I think as the gastroenterologist treating the pregnant patient, it's incumbent on us to talk to the pediatricians, the family doctors, and the OBGYNs to avoid certainly vaccines like the BCG vaccine, which we know has resulted in at least one death in a child born to someone who is on anti-TNF drugs. So the problem with vaccination is that we need new strategies, right? We know that vaccination uptake is poorer in patients with IBD than those who don't. So is this a job for specialists like us, or is this a job for primary care? It's probably a job for us, but that would also mean that to help our patients, we should have these vaccines in our clinic, which most of us, we don't. And so I think that our strategies have been to help patients maintain a vaccine history, whether that's in our notes or not. We write prescriptions for the vaccines to hand to the patient so that they can go to the local pharmacy, clinic, and get their vaccines on time. And then we use checklists, just like the IBD hints checklist that we talked about, so that we are maintaining a cart of vaccines. And it's one extra easy thing to talk about when patients are in remission that sort of spur them to keep seeing you and make sure that we can monitor them. I want to hit home one more time my IBD hints mnemonic. It really helps us remember all of the different pieces, particularly when you don't have the opportunity to print out another cornerstones checklist when you're seeing patients in clinic. So remember, immunizations, bone, dysplasia, depression, hepatobiliarity screening, screening for infections, nutrition, tobacco, and skin cancer. And I have finished early, Dr. Sharma. So thank you very much for your time. I really appreciate the honor to be able to speak to you. And you tell me what you need, and I will try to answer. There's one question already. How many vaccines do you administer at one time? How many days should you wait for the next set of vaccines? Whew, okay, so let's say that you've got the HBV, HAV, zoster, pneumococcal, influenza, and COVID. which is what the list is here from our attendee. My answer for that is that you have time. Vaccines are for long-term reduction in morbidity. So for example, in this one, I would 100% start with your COVID vaccine and give them a couple of weeks. Maybe separating by 2 weeks in between is fine. Maybe separating between 4 weeks is fine. Whatever pace those patients are following up with you in clinic is probably reasonable. Again, these are for long-term issues, not for short-term ones. The other question I got was, if a mother's on azathioprine prepartum, what vaccination strategy for the newborn? Would it be similar to the mother being on infliximab, or go ahead with the schedule? I would say go ahead with the schedule. So what we don't have is data that says that the children that are born to patients who are on immunomodulators are taking in a lot of that drug in their bloodstream. So a normal vaccination schedule for those children, I think, is appropriate.
Well, thank you, Dr. Manish, for an excellent deliberation. And you took the questions from the chat box yourself. See, the issue in our country, one is the cost. The other is the awareness. And obviously, as you mentioned rightly, it is whether it is the gastroenterologist team or whether it should go to the physicians. So do we prioritize something? How do we go about it? With COVID coming in, you said COVID first and then go on with the list. But is there any other way you are prioritizing and leaving aside the cost as one of the issues? And I hand over to Dr. Vikas, my co-chair and a great friend, if any other questions he has.
I would like to partially answer. Firstly, I would like to congratulate Dr. Manish for the excellent presentation. Adult immunization is not an easy topic. It's so confusing. The recommendations change every 6 months. If you see the CDC and no society, as you said, agree on a single vaccination, except for COVID, where everybody said vaccinate. I'm sure soon will we have many of the societies telling this vaccine is good or that vaccine is good. So partially answering the first question, co-administration of vaccines. Generally, live vaccines can be administered at one time. But if you're giving 2 vaccines at one time, then you have to wait for at least 1 month before you give the next vaccine. If you're contemplating immunoglobulin use after use of live vaccine, then you have to probably remeasure the antibody levels of that specific vaccine. And you might have to repeat after 3 to 11 months, that is after 1 year, because efficacy might decrease. Yes, ma'am, I agree. It's always a dilemma whom to go about vaccination. So it's a very nice presentation, and thank you organizers for giving us the opportunity, ma'am.
Any comments, Dr. Manish?
I think that the question about prioritization is important. And I appreciate you adding that let's not talk about cost, but I think talking about cost is also incumbent on this discussion. My feeling about vaccination is it's when you have to prioritize, it's about assessing the risk in your patient. So for example, my patient, I work in a place where we take care of a lot of patients who work at a chicken plant. And so in those patients, obviously I'm going to pick COVID first, but am I going to pick hepatitis B next when they don't have high risk behavior? No, I'm going to pick influenza next, right? Because they're in close quarters with somebody else. But if you ask me about my college student that's going off to, let's assume for a second that college students have high risk interpersonal behavior, then those patients, I'm probably going to pick my HPV vaccines, my hepatitis vaccines. I think that it's not easy to do. Prioritization is not easy to do, but it's incumbent on us to just have a discussion with our patients about it.
Well, thank you. I think we have a reminder from the organizers that we are exceeding time. Thank you, Dr. Manish, for an excellent talk. Thank you, Vikas. And thank you, the organizers, for giving us this opportunity. Thank you, Dr. Vishal.
Thank you, madam. And this talk was an organizer's delight, I would say. Absolutely on time. Thank you so much.
Thank you.
With this, we'll proceed